South Dakota Sanford School of Medicine. Dr. Ward received his BA in chemistry from the University of Arkansas in Little Rock, where he graduated magna cum laude and was elected to Phi Kappa Phi. He went on to receive his medical degree also from the University of Arkansas, where he also completed a residency in pediatrics, where he received the Chairman Scholarship and the Resident Teaching Award. Next on his agenda was a fellowship at Johns Hopkins University and the National Human Genome Research Initiative Consortium in Medical Genetics, where he was the curator of the clinical exome database. Dr. Ward has published in peer-reviewed journals on topics ranging from duplication of the X chromosome in epilepsy and intellectual disability and Crohn's disease. His topic this morning is care for the child with achondroplasia. Please welcome Dr. Isum Ward.
There we go. Okay. Excuse me, it's the first time using a technology like this. I usually just have to speak really loudly. Thank you to everyone for coming out. Thank you, Dr. Marr, for the kind introduction. Can everyone hear me all right? Okay, good. So I'm going to be talking about care for the child with achondroplasia. This is a somewhat rare condition, but most pediatricians will run into at least one patient with this, and it's a very rewarding type of patient to care for. But there are some serious aspects of their health care that I think are not easily accessible to the pediatric community because being such a rare condition, a lot of the knowledge about how to care for these people is sort of shared anecdotally among people who are interested in these conditions. I don't have any financial interest or otherwise to disclose, so we'll move right in. Objectives for this lecture, of course, I'll teach you a little bit about achondroplasia, and I promise will be kind of light on, though I won't really go into like molecular mechanism, bone development, or anything like that. It's purely a clinical lecture. And then we'll talk about the specific comorbidities that go along with achondroplasia and how we address them. And there'll be a lot of information. So at the end of the day, if there's nothing else that I want you to remember, it's just to get a general idea of how important it is if you encounter a patient like this to try to get some outside help and some guidance on how to care for them. So this condition is the most common cause of dwarfism, and I put the asterisk there because that is true for the developed world. In places where growth hormone is still poorly accessible, pituitary dwarfism is still the most common cause. But if you work in the westernized world, this will make up 70% of all people you see with short stature. And it is considered rare because the incidence is about 1 in 25,000 live births. But you actually kind of tend to see quite a few of these people because with a nation that's as populous as the United States, 1 in 25,000 actually gets you to quite a few people with the condition. And then also, people with achondroplasia can reproduce naturally. So many of them have lots of children. So the prevalence, there's no statistics in the prevalence, but it's going to be much higher than this. And as I said before, if you're a general pediatrician, most people I've talked to, older pediatricians I've talked to have said they've encountered at least 1 or 2 people with this in their career. How would you recognize somebody with achondroplasia? Well, when they get older, it's pretty easy. They really, in general, don't look like any other diagnosis. Hopefully, this actually comes through pretty well. The key features, if you're looking at them, is that of course, they're short, but you're looking specifically at the upper arm or upper leg is shorter compared to the lower arm and the lower leg, and that's called rhizomelic shortening. And then if you look at them from this side, they have very characteristic large head with a midfacial depression and lordosis. Now, this is, in general, not something I tell you to rely on necessarily, because differences in variability between individuals, not everyone looks as typical. And there are some other conditions that can kind of mimic it. So what I usually teach residents to focus on, if you're, and this is helpful even down to infancy, you can use this to isolate, is two things. One is to look at the hands. And so if you look at this patient's hands, the three fingers here form what we call a trident formation. You might say, hey, wait a minute, I can make my hand look like that. If you realize when you're doing that, you're spreading your fingers apart. Look at this, there's not any increased space. So this is the natural position. If you leave your hands in a natural position, they're not in that formation. And so that is very reliable. I can't say that every single patient has this, but just about. And it tends to be more evident, actually, in the younger the child is. So this is usually evident at infancy. And the other is just in a plain radiograph. You usually want to get a skeletal survey in the beginning. But usually when I get called about a patient for this first time, the first thing I just look at is the femur, and often I can just diagnose it based on that. Almost nothing else makes a femur that looks like this. The key characteristics are the overall width. If you notice, there's really no difference in width mid-shaft all the way down until you really much get up to the epiphysis. And there's very particular type of medial curving, and this is what also helps you kind of judge the severity, because this curving gets worse with the severity of the FGFR3 signaling that causes this condition. And then I don't have a name for this, but just, I just commit this to mirror just the way that this femoral head looks. It just looks very unique. And based on those two things, you can usually diagnose achondroplasia. And before I go on talking about the specific things we have to do in the beginning, while everyone is still here and fresh, the main things I want you to realize, where can you get help? First of all, any clinical geneticist worth their salt, most of them don't specialize in skeletal dysplasias, but all of them know where we are. Right? There's about 24 people nationwide that specialize in this, and they'll all know us and how to get in contact with us. Or you can remember that there's an organization called Little People of America. They have a website, OPA Online. You can go to local info. There's all kinds of contacts. They list every skeletal dysplasia clinic in the country, and as the providers, as well as local supportive contacts from families with different conditions that can reach out to families that need guidance with this. Here in this system, you have myself and Dylan Platt, the genetic counselor, and we see the skeletal dysplasia patients. The most important thing you need to remember when you see a child with achondroplasia as an infant is the risk for something called craniocervical junction stenosis. And we're going to spend a lot of time talking about this. All individuals with achondroplasia have foramen magnum stenosis, the outlet from the base of the skull into the spinal canal. They all have it to some degree. If it is too severe, then the spine will be compressed, and that's not good. Okay. Before we knew about this phenomenon exactly, we became aware of this because early reports indicated that about 30% of children with achondroplasia died of what they call SIDS. What we now know is that they actually had central sleep apnea due to the spinal cord compression. In other cases, you can have sudden death or paralysis due to acute trauma to the cord being sheared due to this compression. That being said, only about 1 in 10 people with this actually need surgery for this. The way we start to assess for this is pretty kind of controversial. Funny enough to think of it, the things that doctors get worked up about and arguing about, but there was so much argument about this, they couldn't even, on the last set of guidelines, they couldn't even settle if they had to put both in the guidelines because no one could agree. as far as whether you use a CAT scan or an MRI to evaluate the cervical outlet. The advantage of using a CAT scan is you get a really good look at the bone shape. And there are actually established norms for the outlet size. And that's why people feel very strongly about that, but you don't get any soft tissue evaluation. Where I train and how I practice, we feel strongly about using MRI. Obviously, you don't get as good of a bone assessment, but what you do get to see is the soft tissue, so you get to see the actual path of the spinal cord, and the signal change, if there is, can give you an indication that there's compromise of blood supply, which is what those of us who advocate this think really matters in the decision of whether or not you're going to send them for surgery. So what I do in my clinic is I recommend a brain MRI at birth. All right, and that's for multiple reasons. One, because we want the earliest baseline we can get, and two, because typically with a newborn infant you can do it without sedation. It usually goes really well. If you get signal change in the cord, I'll go back and give you an example because I neglected to speak specifically about this. In this image here, this patient has signal change in the cord that indicates compromised blood flow. That's a direct ticket to a cervical release. All right. There's a lot of things going on here. If you look back here, there's this. You probably all see this depression. That's called posterior nicking. That's just a little bit of posterior compression on the cord. And related to that, you see that there's a loss of the posterior subarachnoid space, and you also see a loss of the anterior subarachnoid space, and maybe a little bit of anterior compression. And this can get worse too. You can actually have compression on both sides, and we call that wasting, like W-A-I-S-T-I-N, like someone's waist. And all of those are potentially okay without surgery, except for signal change. So as I said, if they have something like some type of tortuosity, I personally, if they have wasting, if they have indentation on both sides, at the minimum, they're seeing neurosurgery for that, and I kind of advocate for surgery in that case too. But if it's just a posterior nicking or the compression of the subarachnoid spaces, they can go with increased monitoring. My standard monitoring is every 4 months in the first year, and so we may do every 2 months or every month for the first year if that's the case. And the other aspect of this evaluation is actually a sleep study. Right? If a child with standard risk, if their first MRI is normal, I consider them standard risk, and we get them a sleep study as soon as possible, usually about 4 months as early as you can do it. And the indication for this is to detect central apnea as a symptom of cervical compression. And a lot of times people misunderstand that, read about achondroplasia, because most of the time when you look up sleep studies and achondroplasia, it's about obstructive apnea, which they also have problems with. But early on, we're doing it for this indication. If the MRI is high risk, then I usually advocate for an apnea monitor. If we're dealing with a case where it's either normal or elevated risk, but we don't think they're ready for surgery yet, how do we tell people to care for children? Well, first of all, neck precautions are really essential throughout life, people with achondroplasia. So I kind of jokingly tell people, most people when they have their first child, they feel really scared about the newborn infant's neck and supporting it and everything. And they quickly learn it's maybe not quite that serious. I mean, you need to, but it's not the end of the world if you actually, let the kid's head fall every now and then. What I tell families is, in this case, go with it. Everything you're scared of, continue to feel that way. And always, and avoid ever even one time allowing their head to drop or something like that. You absolutely have to keep relatives from picking baby up and slinging them around and shaking them, all kinds of things like that. Motorized swings are way out. Anything that's going to cause repetitive motion at the neck is considered a risk for injury. And then when we see them at our exams, which again are kind of based on our risk stratification, we're looking for a couple of things. We're looking for weakness, and for a high cervical, you're looking mostly in upper body, but it can be diffuse. This is something that I think is very tough if you're a general pediatrician. Children with achondroplasia are naturally hypotonic. And so if you're not used to that, you might be fooled into thinking it's weakness. And there's nothing ever wrong, always err on the side of caution of looking at the brain, but it can be difficult. You're looking for usually asymmetric weakness. And then abnormal reflex. You would expect hyperreflexia, but I've seen it go both ways. If you get an abnormal exam later, then your follow-up kind of depends on what your past is. If the brain MRI was previously normal, you're going to repeat it. And since this time they're going to be older, you're going to need to do sedation. We're going to have them do an inflection and extension, which can maybe, sometimes the symptoms can be due to because the compression is positional. If it was previously high risk, at that point, then we get recommend surgery. This continues to be a risk for them throughout their life. After a 1-year-old, the risk plummets just because their skull grows like anybody else's. And as at 90% of the time, they generally outgrow this risk, but it never goes away. People have been reported with sudden death even to adulthood, unfortunately. And so we, at every yearly visit, we talk about neck precautions that are particular to that age group. In toddlers and such, it's things like making sure that their neck is always supported. If they're in a stroller, you want to not use strollers where the head is pushed forward. You want to, as they get older, contact sports are way out. Oftentimes they will do all the same sports. Early in life, things like soccer and football tend to be, not focused on impact when you're talking only 5, 6, 7 years old, but when they get to grade school and high school level, they do, and then they can't participate. And there is actually a separate organization just for people with short stature that focuses specifically on non-impact sports called the DAAA. And it is a pretty big organization. A lot of kids that are successful, they travel around the world to compete in these sports. And so we recommend things like that. The next major issue is sleep apnea. To revisit, I mentioned that we do the sleep study as soon as possible after birth for central apnea. There's no consensus about whether or not that should ever be repeated. Generally, I don't, just because it kind of doesn't seem to make sense to me. If you do a cervical release, then you've fixed the problem. There's no real risk the cord's going to be. And I've never seen any logic yet, but some places do this. They do another one post-surgically to make sure they're still not having central apnea. I don't know if maybe they're worried that the patient incurred an actual ongoing injury to the cord or not. We don't really know if that ever happens. And as I said before, sometimes we use apnea monitors for this. Sleep studies come up again throughout life. Obstructive sleep apnea occurs 75% of people with this condition, but it's spread out throughout the lifespan. And this is due to the midfacial hypoplasia that develops. All people with this condition have some narrowing of their sinuses because of midfacial hypoplasia. And even the ones that don't have obstructive apnea, I have 90% or more of my patients with achondroplasia, I just give them nasal steroids empirically where they have allergies or not to shrink their turbinates and improve their airway, because even when they don't have apnea, they tend to just have difficulty breathing through their nose. There's no recommended automatic screening for this. Just take it year by year. The main thing you might want to know as a general pediatrician is that everybody with achondroplasia snores. So if you just ask about snoring, you'd be doing one on everybody, and that's not actually considered abnormal for them. And if you just if they just have light snoring, then usually the sleep study is normal. So you have to look. But they're more likely, if they're having obstructive sleep apnea, people with achondroplasia are more likely to go right to really severe sleep apnea. And so you get more of the classic symptoms like morning headaches, choking, sputtering. And another one is extreme positioning. And I think some of this has to go in because children, they're hypotonic, they're really flexible. I hear some interesting stories about this. I've had kids where they're sleeping basically with their back of their head, their occiput almost touching their buttocks, or some kids sitting upright, getting pillows, and then like sleeping upright, going forward, and stuff like that. That's a dead giveaway that you've got someone who has bad sleep apnea, and certainly a lot of them ends up with TNA. And but rarely do they need any kind of reconstructive surgery of their sinuses. The other big category is growth and development. I think this is one of the areas where there are a lot of nitpicky details. They don't get distributed to the pediatric world. Don't forget to look at your kids' height when you see them. It sounds funny to say, but I've seen a few kids who had other illnesses that were you could have seen something that was going on by the fact that they were falling off their growth curve. There are specific growth curves for this, and some providers have tended not to look at the high growth curve just because they're short, and they don't think about that. But you need to monitor it. They still follow their own growth trajectory, and not following that is still an indication of secondary illness, just like it is with anybody else. Weight is a very difficult subject for children and adults with achondroplasia. What I usually tell them is that your genes do not talk to each other. In other words, the other 20,000 genes in your genome do not know that you're 4 feet tall. Right? They are building a body, a fat composition for someone of average stature. And you see this a lot. Almost all patients with achondroplasia will seem overweight or obese. And you can't really use weight alone for this because judging whether or not someone is healthy, because their stature is important. You need to take that into consideration. And skin folds are way out because they are all predisposed to abdominal fat deposition. And so we evaluate, of course, like we do everyone with an individual basis. Is their weight consistent? Are they having large changes in their weight? And more importantly, is their function limited? The real risk, I'll talk a little bit more about this, with achondroplasia is actually functional limitation. They get so heavy they have difficulty moving around and ambulating, not so much the metabolic concerns you would think with average stature individuals. To give you an idea of how things differ, this is on the left is a standard growth chart for BMI in children. On the right is an achondroplasia-specific growth chart. They're almost getting towards sort of an inverted pattern, right? The achondroplasia kids start out actually in general a little bit lower because they're small size, and then as opposed to typical children where there's a kind of a decrease over time. There's actually a rapid increase and then a more gradual increase in adolescence because because they're shorter, they're not putting on as much lean muscle mass. And basically what this comes down to, what I tell you is that for people with achondroplasia, just add 5. So in general, 30 or higher is considered overweight, and a 35 or higher is considered obese in achondroplasia. And the implications of that are questioned. We don't at this time really manage nutrition any differently. There's a couple of studies that have tried to look at estimating dietary requirements. There's a little bit of evidence that the standard equations for calculating someone's basal energy expenditure overestimate a little bit for people with achondroplasia. If you can do most places, a calorimetric assessment is not really practical. But I try to get it for people if they're really having a lot of problems with weight gain. But the other thing we learned from doing these few studies is that the abdominal obesity appears to be intrinsic to their condition. And you see this in animal models, and there's studies ongoing seeing if that actually is modulated by changing the activity of the gene. It's changed in achondroplasia. And this is further supported by the fact that the obesity-related complications that we classically think of, like diabetes and high blood pressure, don't usually occur in achondroplasia. An interesting thing that gets tossed around, not systematically studied, but we talk about this. We actually talked about this last year at the annual conference, is that none of us had ever observed an adult patient with achondroplasia of any weight or BMI that has developed type 2 diabetes. They would appear to be resistant to that in some way. Head circumference is important because the head growth is markedly different in people with achondroplasia. As a sort of reference when we talked about how you can recognize people, most people with achondroplasia will have large heads when they're born, okay? And they'll follow a unique trajectory. Even if you're using the achondroplasia-specific head growth charts, often there are transient accelerations of head growth, and we don't really always know exactly why that is. And you pay attention to this because it can be due to hydrocephalus. People with achondroplasia are predisposed to hydrocephalus, but not nearly to the degree that the general medical community used to think. All right, we've had some time to look into this, and now the estimation is between about 2 to 4% only need a VP shunt. That being said, a lot more kids than that have gotten shunts, even in the United States, and especially overseas. Most of the patients I see that are adopted from other countries have gotten VP shunts. Why is that? Well, people with achondroplasia are, I call them hydrocephaloid, and meaning it just looks like they have hydrocephalus. So achondroplasia does cause megaloencephaly. That's normal for them. A larger brain means larger ventricles. Most of the time when radiologists are looking at radiographs, they just look at the measurement of the ventricle itself. And the reason for that is because you would like to, what I mean is you would like to judge someone's ventricles, and you would think that this would be true in all people. You would judge their ventricles versus the size of their brain versus the size of their head. That's actually kind of difficult to do. You can do that. There is something called the Evans ratio, or Evans index, which this picture indicates. These two lines. Basically, you at a specific level, you're going to measure the width of the ventricles versus the width of the inner table of the skull. This isn't used too much because when you do this, you can't differentiate whether or not the ratio is elevated because of dilation of the ventricle due to hydrocephalus, or if it's an ex vacua change. And so most of you probably, that's why radiologists don't use it much. However, in achondroplasia, some of us think it might be a little bit more useful because in this case, if the ratio is elevated, we know why, and we also know the condition doesn't cause brain atrophy, so we're not expecting ex vacua. So we feel like it's a little bit more useful, and this is an area where we're getting into things that are patently not systematically studied, but it does go into how I assess patients for this. So the first thing to understand is why people with achondroplasia get hydrocephalus. It's not because of what you're used to, what we think of failure to reabsorb CSF or blockage, some sort of physical obstruction of the ventricles. It's actually due to venous congestion. Just like the foramen magnum gets stenosed, so are the other outlets from the skull, and this includes the jugular veins, the largest veins draining blood from your skull. They get stenotic as well. And this seems to happen, you seem to see evidence of this most between 2 and 5 years old. And if it becomes serious enough, they can have hydrocephalus from this, and you will get the usual symptoms: papilledema, headache, morning vomiting, etc. There's no easy route in deciding who should get a shunt or not. The way I look at it is, certainly if they have the symptoms, that is the most important thing, independent of head size. So this is where I look at things like the Evans index. I know children with this are often going to have an elevated Evans index. They're going to have generous ventricles. Past information shows us that some kids with an index which is getting close, even in the mid fours, can be tolerated. They can outgrow that. Whereas when the index was created for average stature individuals, anything above 0.3 is considered suggestive of hydrocephalus. They can tolerate much higher levels. But if it's above 0.5, then if they didn't have symptoms, I would be really surprised. But if they didn't, I would still be sending them to a neurosurgeon to ask them, are you really okay with this? If they have positional symptoms. So because of the anatomy of the skull, if they're stenotic in certain ways, sometimes the stenosis can be increased when the patient pushes their head downward. And I've never done this myself, but I have been taught that you can actually sometimes just elicit the classic Cushing response with elevated blood pressure and bradycardia. Right, clinic, if you get that, they need a shunt for that as well. Of course, if they don't have symptoms, I'm not really worried about how large their head is. And if they have symptoms and their ventricles are, frankly, not enlarged, I'm going to be suspicious of some other cause for this. Or if their symptoms are only external. And by that I mean some kids, if they have, even if they have slightly generous-sized ventricles, but the only symptom they have is accelerated head growth, and so a lot of times they will have dilation of the veins outside of their head. I don't worry about that too much either. And typically, they'll go up about, they'll usually go about 2 centile lines for a period of about a year to a year and a half, and then re-establish at that new centile line and not need a shunt. Development is definitely different in children with achondroplasia, and it's pretty adorable. As I said, they are all hypotonic. We're not exactly sure what it is, if it's a primary neurological cause, or difference in biophysics, but they're just different. There are charts for this available, but an easy thing to remember is just add about 6 months to the range for any motor milestone. Other interesting things to remember: most kids with achondroplasia do not crawl. They can do these other things like bear walking, but the most common one is what they call the snowplow. And so, of course, walking takes a while because if your head is so much larger and heavier, it takes you some time to balance. And they often get around this by using their head as like the third leg in the tripod and scooting around. So every year when I go to the national conference, there's about 20 kids who have these scabs on their forehead from pushing around all the time. Some of them just roll everywhere they go. Key points on this for parents who are new to this: never force sitting in a child with achondroplasia. They have a little bit of kyphosis at baseline, and if you allow them to sit in a slump position, you can actually make that worse and make it permanent. So we just tell people don't worry about it when they'll sit when they're strong enough. And the other big note is speech should not be delayed. When you look at the specific chart for this condition, they will provide slightly higher ranges. I don't think they're significant. I generally expect them to have on-time speech delay, and I treat that just like any other child if they do have any speech delay. Are there, in general, neurological problems? There's good reason to suspect that there might be. Right? The gene that causes this condition can cause a variety of other conditions that are more severe than this. Things that are called like Satin syndrome, thanatophoric dysplasia. And when those are skeletal dysplasias that are not compatible with life, but when they occur, the brain is grossly abnormal. They have grossly abnormal temporal lobes, poor development. You occasionally see temporal lobe gyration abnormalities in people with achondroplasia in a small percentage. So every reason to suspect this is involved in brain development, it would have some effect. And although we don't have a specific very good specific numbers for it. We do know that the risk for true developmental delay, autism, epilepsy, temporal lobe malformations are slightly higher than they are in the general population. We just don't have a good handle on that. Because of this, I recommend at least one physical therapy evaluation to be done, irrespective of whether or not you think their motor development is normal. And as I said before, I would treat behavior the same as I do speech. I would expect behavioral development to be typical. If it's not, they should get promptly referred for any concerns there. As a child ages beyond infancy, adaptive functioning becomes an important ongoing issue for routine care. There are too many for me to go over, but the biggest ones, cars are a big deal. Of course, they're going, because of their size, they're going to spend longer in car seats. When they get to a booster, they need to stay in the booster for a long time. Really, with their height, an individual with achondroplasia should be in a booster for their entire life. All right. That being said, it's a very hard sell to get a 12 or 13-year-old child to stay in a booster seat when their friends are not. And you just kind of have to, sometimes you kind of have to just let some things go. I always tell people it would be safer, but I don't get a lot of adherence usually until they get to be adults on their own and they worry more about their own health. And of course, as they enter adulthood, they'll have to have a lot of modifications to a car if they're going to need to drive. At school, the most important things are that the study environment be appropriate. They need to either have a desk that is custom built for their size, which is usually not a good option because that's going to change over time. The best is to use a regular sized desk and use a block for the feet and a cushion for the back to make sure that they are in a proper sitting position. They tend to like this better as well because then they don't feel as different sitting in a tiny desk. As they age, they will also need greater assistance with getting between classes. Shorter legs mean decreased walking speed. So especially by the time they get to high school, they're not going to be able to make the quick transit times between schools, especially not with a 50 or 60 pound backpack. There's no ways to get around this. Usually early on, you can give a wagon or something like that. Maybe later on, they either have some sort of motorized mobility assistant or an aide to help them get from class to class. And for writing, because again, to get the change the configuration of the hand, it is often difficult for them to use a standard writing implement. They typically need something with a little bit larger bore, make it easier to grip, and a tip that is wider and softer so they don't have to press down as hard. Bathroom access is an absolute essential, and another example of the kind of day-to-day things people never think about. People with achondroplasia have shorter arms, so they have to learn a different way to clean themselves after they go to the bathroom. They actually do this by squatting down and reaching on the front, as opposed to reaching from the back because they can't reach that far. Social functioning may or may not be a big issue. It varies so much depending on the person's home environment and their school environment. You can get family conflict for various reasons. Obviously, as you might expect, a good number of average stature families, and 70% of children with achondroplasia will be born to average stature parents, have some difficulty adjusting the idea of having a child that has short stature. But this can actually sometimes go the other way. A couple with achondroplasia has a 25% chance of having a child that's average stature. Sometimes they wrestle with that a little bit. Of course, within society, there's all manner of things that can be encountered. The perception of the limitations and self-consciousness about being different, that really varies on the individual, how they do that. I think bullying, harassment. Bullying, I think we have a pretty good hand on. I don't hear much about this at schools. Harassment is a big problem actually in the adult world. A lot of my adults still tell me, they laugh about it because they don't even think about it anymore. But they get people following them around, sneak pictures of them, come up and ask them odd questions and things like that. That is just a struggle for them, and you kind of have to, I don't push people on it, but you need to try to keep an open ear for indications that something like that has bothered them. This is one of the reasons why I really encourage participation in groups like LPA, because even when they're young, even if they don't think so, I tell them they should go to at least one meeting. It's really incredible. Sometimes I see the kids who come for the first time, it's the first time they step into a room full of people that look like them. It's really profound. And last, and not least, but you might have been kind of surprised that I listed orthopedic concerns as the last aspect of achondroplasia, because I think that it's probably the most well-known complication, which is tibial bowing. The tibial bowing is pretty much present at a constant rate in people with achondroplasia. It's actually a little bit more complicated. That it's a combination of bowing, torsion, and recurvatum. So the surgeries can get a bit more complex than you would get from just idiopathic childhood bowing. But nevertheless, just like with the other type of surgical interventions, more children with achondroplasia get correction, get 8 plates and such than probably need to, because just like idiopathic tibial bowing, a lot of the time it will self-resolve over time, just the child walks normally. I don't concentrate on too much of this because, honestly, at the end of the day, this doesn't leave a permanent indwelling device in the patient, so I don't get too upset if they maybe get an unnecessary. The worst they get is they get really straight legs, or maybe it didn't matter. But when we assess this, there's also not really a good way to tell exactly when someone has to have surgery. Of course, you look at things: can they walk straight? Are they steady? Do they fall a lot? Can they run without falling? Big warning sign for kids is if they have something called lateral thrust, where the knee suddenly juts out to the side while mid-gait, while they're walking. That's a indication of instability. We also look at things like the thigh-foot angle to give an indication of how the foot is aligned with the joints higher up. Pain is not usually an indication. Most kids with achondroplasia have some pain in their legs or often their knees after exertion, and that's pretty typical for them. Other things that are normal with regard to exercise are squatting. This is not an indication of problem with the legs. The lower portion of the spine is also slightly small, and this causes some, I'd say, very minimal kind of claudication over time, and even in, all children will usually have to squat after about an hour of activity to sort of rest their legs, and that is perfectly normal for them. Other things that happen with the skeletal system, lordosis happens to some degree in all. I've never heard of it requiring surgical intervention. Even when the spine is at almost a 90-degree angle. The elbow extension, there's limitation to extension at the elbows. That's very rarely severe enough to require surgery. The rest of the joints, interestingly, are hypermobile, especially the hips. And you kind of take that on a case-by-case basis. Despite that, people with achondroplasia in general do not have problems with joint pain. And a quick wrap up, kind of review of other issues. Generally, there's not many. A couple other things like if a person with achondroplasia has urinary issues, you need to be thinking of neurological causes. And also, people, because of the gene change, the FGFR3 change, people with this condition, still not common, but at low percentage, get acanthosis nigricans, and it's not due to metabolic syndrome or hyperinsulinism. It's just something that can occur. the big picture for all of this is that people with achondroplasia are really very healthy. When they go into adulthood, there's a couple of other complications you have to look out for, but in general, they're very healthy people. They get typical jobs, they have typical families, they are typically functioning in every way, academically, intellectually, and they are proud to be who they are, and are often actively involved in the LP community, which is why this is, I think, so rewarding for pediatricians. I think one of the greatest things you can do is take a child who is destined to be healthy and help them avoid major catastrophes and keep them away and produce a healthy adult. And you can certainly do that if you're aware of the things that can go on early. So with that, I'll ask, I think first, thank you for listening, and I'll ask, I think first, if any of the remote listeners have questions. Okay. Does anybody in the room have questions? Yes, sir. Oh, sure. Yeah. It's interesting. They all have C-sections. Usually uncomplicated. They all have C-sections due to there's always cephalocaudal disproportion. And we've talked about this before. Women with achondroplasia had babies before C-sections existed. And our only assumption is that a lot of them, we don't know if maybe we underestimate the increased flexibility. If they really can't, their pelvis can dilate to the point to accommodate, or if just a lot of them died from it. But it did happen. But certainly it's perfectly safe with a C-section. Yes, sir. Right. What is the bumbo seat? Is it some type of? Is it?
It's a seat design. You put it on the floor and it holds the child
Okay.
well before they're able to sit on their own. Any child, typically or atypically developing, it can hold almost
Okay.
any child in a sitting position.
Okay.
It forces the sitting milestone well ahead of schedule.
Yeah. Okay. But it's not bouncy.
No, it's stationary.
If it's not
But
bouncy,
it's very kyphotic.
Okay. Oh, it is. Yeah, if they're going to be leaning over, the question I have is, if they're going to be leaning over, then it's absolutely no. If you can haul, and I tell them it's okay. If you want to sit them up, you got to make sure that they're propped up enough that their shoulders are back, that they're resting their upper body in a lordotic position. Yeah.
Are these babies almost always prenatal diagnosed?
No, not always. I don't know the top. I don't know if we know, but if there is, I don't know it. The percentage that do get prenatal diagnosed. Oftentimes, there's just a appreciation of short and long bones, and they're kind of. Oftentimes, they'll say maybe achondroplasia, but usually they're just not sure. I don't. I think if they're prenatally diagnosed, it's only if the mother chooses to undergo prenatal genetic testing. I still every now and then. Still get a child at about 3 or 4 months old for poor growth, kind of because they have mild features. No, not very often.
So short stature is a big thing to suspect diagnosis. Any other physical findings that we can?
Yeah. So for babies, again, it's the appearance of the femur and the hands what I go off mostly to make the diagnosis visually, and of course. Short stature, and any child should get a genetics referral, especially if it's more than 2 standard deviations. Other questions?
There's no questions from the remote sites.
Okay. Thank you again.